Good morning, good afternoon, good evening, wherever you may be. Can you hear me? Yeah, okay, so.
Peter, sorry, Peter, we can hear you, but reminder that we are a lot closer so we can.
Yeah, so in fact, I switched off my camera, so I stay closer to the screen.
No problem, thank you.
So before starting my presentation, I just inputted 2 comments with respect to the last questions we had. Indeed, if you have a very big word, what the WHO protocol recommends, and it's probably could be also done with the GPPS, is that you can split the word in 2. So bed 1 to bed 25 would be, I don't know, gynecology ward 1, 26 to 27, 26 to 50 gynecology ward 2, for example. So that you're sure that bed 1 to 25 is done on day 1 and finished, and bed 26 to 50 is done on day 2 and it started and finished the following day. But that's something, I mean, just an idea which has been happening with the WHO PPS when we did it in Tanzania. So back to my presentation. I'm Peter Zarb from Malta. I'm trying to. Okay, so what I'll be mentioning is first there's a short icebreaker, some generic epidemiology PPS information, some of which is a bit of an application which has already been discussed by the previous presentation, so I'll be quite rapid in going through those slides. Then a lot of detail about the WHO PPS methodology. I will not go through the actual protocol and all the forms because that would take too much. Some pearls and pitfalls from experience. And finally, I'll wrap up with the key take-home messages referred to as conclusions. So now I'll pass on to Kieran for 2 Menti questions. So if you can now please go to menti.com. Oops. Kieran?
Thanks, Peter. Yeah, so if we can, Peter, if you could share that screen again, just so everyone has the code, that would be great, thanks. And then I can share my screen to show the results.
Kieran, I think if you share your screen with the results, it shows the code anyway, so you can just do that now.
Yeah, sure, no problem.
So Peter, don't worry about sharing.
Right.
Great, yeah. So if everyone can go to menti.com and on my screen, you should be able to see the code here. The code is 8431-1692, and there will be 2 questions to answer. So if anyone has any issues, please just put it in the chat.
I've just posted the link so you can directly click on it and access the code. Peter, we've got colleagues saying the volume is still a bit low, so sorry.
All right, so I'll get even closer to the...
Yeah. And apparently they loved your Eurovision entry in Malta.
Pardon?
Someone, Sarah's just said they loved your Eurovision entry.
Actually,
let's not talk a bit more because that's the next question, isn't it?
No, it's not the next question. But actually, I'm one of the few Maltese nationals who, let's say, not follow it, not to say anything more damning. So I think with respect to this question, we can stop here.
Next question.
Next question, please. So they've already answered, all right. Okay, I think I can take... Kieran, I'm taking over again, if it's all right.
Sure, Peter, I'll just stop sharing now.
No. So, okay. So indeed, Malta is a member of both of the European Union and the British Commonwealth. Some notes about me: I'm a pharmacist, not so young anymore. I've been working on antibiotics since 2000, and also specifically dedicated to intensive care since 2008. Obviously, with this pandemic, I had to give up a bit of the intensive care duties. As Anne said, I was involved with ESAC and now at ECDC ESACnet. I'm the secretary for the National Antimicrobial Antibiotic Committee, which is the AMR board in Malta. And I've also had experience as a facilitator on antimicrobial consumption and antimicrobial use with the WHO. With respect to consumption, it's the longitudinal total consumption, whether it's hospital or community or overall, whereas antimicrobial use is the term we give to the PPS. So data. Data can be valid, reliable, or none of the above. So taking here the first green circle, the data is both valid and reliable, which means that the data collector applies the definitions in a consistent and correct manner. In the second example, which is brown, the data collector is applying definitions incorrectly in the same way every time. So it is reliable, it is the same, but it's not valid. And then the last one, it's the worst case scenario where everything is all over the place and there's neither definitions nor correctness throughout. Incidence and prevalence has been described in the previous presentation, but if we take these horizontal lines as cases, they have different durations and they start and finish at different points in time. And the incidence is 6 cases in this period of time, whereas the prevalence across this arrow, I don't know whether, yeah, across this arrow is 3 cases because the first and the third cases have finished and the 6th case has not started yet. So this becomes important when we look at point prevalence surveys. A note on prevalence surveys with respect to antibiotics, it's, as opposed to consumption, it provides information on dosing and indication. And from that, you can derive whether the right drugs are used for the right indications. And that's a target for quality improvement. So if you see that many people are using, I don't know, piperacillin tazobactam for community-acquired pneumonia, which should not be the case, maybe co-amoxiclav would be sufficient. You should instill local guidelines targeting that area. So that's one point. So evaluating appropriateness. The negatives, it's quite resource demanding. Surveyors must be clinically trained because very often you will not find the name of the indication written. You will not have pneumonia. You might find consolidation, lower lobe. And you have to translate that, be able to translate that as a pneumonia. Another issue is disruption to clinical work. And not always the question about anonymization and safety of data storage must be ensured. So if you do not have a copy of the methodology, it can be accessed from the WHO website. Here is the link here. Maybe later on I can share it directly with you. So going to an overview of the methodology. So who is it for and who is it not for? So usually, well, as a start, if you have the protocol, you can run the survey, but you, as an individual hospital, but you will not get support from the WHO country office or WHO regional office or WHO headquarters, but you can run it. However, as a general rule, it's done top down. So the country decides to participate through the WHO country office. and the individual hospitals are selected or invited centrally by the national coordinator, and I'll come to that in a few slides. It is specifically developed for low and middle income countries, as opposed to the ECDC PPS or the global PPS, which are originated in Europe. I mean, this has specific fields like the reason why a dose was missed, and I'll come to that in a few slides down the line. To get WHO support, and when I say WHO support, I'm not referring to financial. This is not a financially supported initiative, but technical support. It's not given to individual hospitals or groups of hospitals, but only at WHO country level. The data structure is more or less similar to the global PPS, but obviously there is the national aspect of it. And there is ward data, hospital data, ward data, patient data, and the patient data, then it's split further into the indication data, the antibiotic data, which are interlinked, and for those patients in whom there is a microbiology specimen, there's also that aspect involved. Some considerations for the national planning. So, as I said, it's top-down, so the authorities, usually the Ministry for Health, which choose the national coordinator or national coordinator team, which would still have a leader. And this team will take the necessary background information about the country, the number of hospitals, the bed size of the hospitals, and the number of hospitals and the number of beds per hospital will be important when it comes to selecting hospitals. There are two options, random or convenient sampling. When we go through random sampling, you list the hospitals by bed size, for example, and if you have 100 hospitals and you need to take at least 30, you choose every third hospital. So like that, the sample is random and systematic, and it's unlikely to have bias. Convenient sample, on the other hand, is based on whether the hospital is willing to participate or not. And that's obviously, that can be biased and cannot be taken if you use a convenient sampling. You cannot take that as a picture of the total country situation. And obviously an invitation can be optional or mandatory, depending on the health system. But obviously, if it is optional, it can still remain a valid systematic sampling, because if the one that rejects, the next one will be selected, and it's still considered as a representing the country. Also, the national coordinating team must ensure training of local hospital coordinators and the central investigator team, which might act as train the trainers if there are local personnel involved in the collection of data at the hospital level. At hospital level, as mentioned by the GPPS presentation, busy dynamic wards may be difficult to get access to, especially if there's the ward rounds going on. So one must be careful to visit when it's maybe less busy. Find space to work without disrupting the ongoing duties of the ward. And importantly, if there isn't sufficient information on the patient notes or the admission book or any form of documentation, you can discuss with the ward staff or with the prescribing clinicians about the indications of treatment. However, it is important to highlight that these are not interventions, and if you see something which might even seem stupid, it's, as a ward assessor, you are not there to give advice and to recommend changes. So no interventions whatsoever. Good communication is important, so the wards have to First and foremost, at national level, the hospitals have to be advised in advance of the dates of the survey. Similarly, at ward level, at hospital level, the hospital coordinator needs to communicate with the wards, informing them of what the PPS is and on which day their respective ward will be done. Timeline, I think this applies also to GPPS. A hospital has to be finished within a maximum of 3 consecutive weeks. And this refers to the specific hospital, not at national level, at hospital level, 3 consecutive weeks. So you cannot start doing 1 day a week for 2 months. It's 3 days, 3 weeks maximum. And the duration of the survey will depend on the size of the hospital and the size of the team, as well as the experience of the team, because the more experience you get, the more likely you'll go fast through the patient notes. So these are things to be thought of, and ideally there should be a pilot phase before carrying out the actual survey so that all investigators are familiar with the system. With respect to hospitals, there are different types, and the definition of primary, secondary, tertiary, and specialized hospitals is not fully standardized. So you might, but as a general rule, a primary hospital is quite local. Secondary is somewhat more of a regional. Tertiary hospitals are usually the reference centers, and in many countries you would have one national tertiary hospital and some satellite tertiary hospitals in other big cities. Specialized hospitals refer to hospitals which deal only with one specific condition. For example, infectious disease hospitals, or even TB or malaria hospitals. So those are specialized hospitals. In many countries, there are groups. In the UK, I'm familiar with the term trust, so NHS trust, but in other countries, they might be referred to as chain merger group. With respect to hospital ownership, it's also important to classify the type of hospital. And some countries will only have, for example, public hospitals registered and participating. That obviously cannot be taken as a systematic sampling, and it will be biased, reflecting only the public sector. Something very common in low and middle income countries is the next one is private non-profit hospitals, which are not common in high income countries, but it's something to keep an eye on. Inclusion and exclusion criteria are identical to the GPPS, so I will not spend too much time on the slide. With respect to ward types, they are similar but not identical to the GPPS. So we have pediatric, adult, and neonatal. With respect to pediatric, there's medical ward, surgical ward, high-risk wards, and intensive care. Similarly to the adult, with respect to neonatal, there's neonatal medical wards and intensive care. Neonatal medical wards usually are the nurseries, if these are not part of the labor wards. So that's something to keep an eye on. Mixed departments, you can have, if there's more than 80% of patients from the specific one group, the ward is classified as that group. But you can have mixed adult wards, mixed adult and pediatric, or mixed pediatric wards. An important note is that some specialties like orthopedic, otolaryngology, ophthalmic are usually classified as surgical departments. So there's no subspecialties for this type of ward. And the definition of high-risk wards includes wards that are more likely to have higher antibiotic consumption. And these include hematology wards, oncology, burns, transplant, and infectious disease wards. Please note that intensive care units, they are sort of very high risk. So they are not part of this category. They are a category of their own. With respect to patient level data, the WHO point prevalence survey uses patient data on all patients. This is similar to the ECDC PPS and different from the global PPS. And this is an important aspect if we're looking at antimicrobial use and risk factor. For example, if a patient has a urinary catheter, it is usually more likely that the patient will have an antibiotic or not. If the patient is intubated, if the patient has a vascular catheter, so on and so forth. So that's why this kind of information is important. Also, there is collection of data on whether the patient has TB, malaria, or HIV, but at this point in time, it might change in the future. There is no collection of data of treatment for these conditions. But this is also important to look at the issue whether patients with these conditions are more likely to be prescribed antibiotics than the other patients. So that's why you need to have all patient data. The indication for antibiotic use, I'll come to that later, and the treatment, the actual antibiotic and indication, and whenever there is microbiology specimen, this is to be collected as well. I will not go through the patient form, but this slide is here to reiterate that it is for all included patients, and there is an aspect of core components and optional components. If you're participating, just carrying out the survey on your own, you can decide. But usually, if it's coming from above, from the Ministry for Health, for example, usually what's to be included and what's not is decided centrally. So it's not that one hospital from country A will include optional data and hospital B will not. So that's standardized at national level. The number of antibiotics, this is something which might not be collected in other methodologies. So the first part here in gray is if a patient receives benzoyl penicillin followed by ceftriaxone, the reported number of antibiotics should be 2. So if the patient received amoxicillin followed by amoxicillin and clavulanic acid, here it is also 2 because amoxicillin and co-amoxiclav are not the same drug. Similarly, if a patient received ciprofloxacin, but treatment was interrupted for whatever reason, maybe out of stock issues, or the patient could not buy it, or they thought the patient was better and then developed a fever later, and it started after a few days, being the same drug, irrespective of route of administration. Here the number of antibiotics should be 1 and not 2, because it's the same substance. It does not depend on the route of administration. Then there are the indication antibiotic forms. These are only to be filled in for patients or actually on antibiotics, not for all patients, obviously, because if there's no antibiotics, there's nothing to fill. The inclusion-exclusion criteria are quasi-identical to the global PPS. The special cases, I think, are the same as well, but I'll go a bit into more detail. Sometimes we find patients who are given a drug less frequently than once daily. For example, gentamicin every other day. If on the day of the survey the drug is not due, the patient is still on treatment because the patient took the drug yesterday and will be taking the drug tomorrow. So the frequency would be 0.5 because it's every 48 hours. If it's every 3 days, the frequency would be 0.33. Obviously, if a patient is on antibiotic A at 8 a.m. this morning, but the treatment changed to drug B at 10 a.m., only antibiotic A is to be reported because remember the snapshot, the photograph is taken at 8 a.m., not at the time you visit the ward. For surgical prophylaxis, you look back 24 hours, which is similar to the global PPS. This is a summary of what I've just said about inclusion exclusion criteria. I will not go through it, but For your convenience, it's there when you get the PDF form of these slides. It's a good summary, I think. And with respect to the surgical prophylaxis, when I come to the indications, I have a slide which will define better what I was speaking about here. So in this methodology, you have to use the INN for drugs. And so, for example, if it's amoxicillin and clavulanic acid, it's amoxicillin, clavulanic acid. It's not co-amoxiclav. It's not any brand name. It's the INN that has to be used. The dosing unit should be reported as well, and this and the number of units per day, because this will help define your prescribed daily dose, which might differ from the WHO collaborating centers defined daily dose. With respect to antibiotic data, also there is an aspect of combination products, which I will discuss in the next two slides. So taking example 1, co-trimoxazole, it should not be written as co-trimoxazole, but the product contains 160 milligrams of trimethoprim and 800 milligrams of sulfamethoxazole, and is given every 12 hours. So in the form, you will need to write trimethoprim, sulfamethoxazole. With respect to unit dose, it's 960, so it is 160 plus 800. The unit dose is in milligrams. The unit dose combination is 160 milligram, 800 milligram, and the frequency is 2. And the data has to be inputted in this way so that the WHO can evaluate it at a later stage. With respect to co-amoxiclav, it is different because the name already writes amoxicillin, clavulanic acid. But with respect to the dose, you only include the dose of the active ingredient, which is the amoxicillin component. So it says 500, not 625. With respect to unit dose measure, it's milligram again, but unit dose combination, it's 500 milligram, 1 to 5 milligram. So in this case, both the antibiotic and the beta-lactamase inhibitor are included. And obviously the frequency is 3 times daily, so it's 3. Going to indication type, a slight difference from the global PPS, where hospital-acquired infections are grouped as one. Then you can do the diagnosis, which can be a wound infection as opposed to a CNS infection, etc. But we don't have HAA1, HAA2, HAA3, 4, and 5, etc. So it's a bit simpler from this aspect. There's surgical prophylaxis, which is identical to, and medical prophylaxis identical to GPPS, and others and unknowns are classified as other. And for example, erythromycin used as prokinetic as a motilin agonist is one of such indications. The definition of medical prophylaxis, this is not does not include all possible indications, but the most common indications include prevention of opportunistic infections in immunocompromised patients, such as those on chemotherapy, HIV patients, patients with cirrhosis, prevention of UTI in patients with urinary tract defects. But I've seen other strange uses for this. For example, there was a case where one of the audience said, what about prophylaxis being started post-surgery? When a drug is used just in case, the clinician is not trying to prevent an infection. So that does not fall under medical prophylaxis. It should fall under treatment of what they're trying to prevent. With surgical prophylaxis, there are 3 options. 1 dose, even if it's a drug that's given once daily. For example, ceftriaxone is given as a once daily dose. But if it's 1 dose, you don't say 1 day, it's SP1. If it's multiple doses within 24 hours, that's SP2. So if it started, let's say it's co-amoxiclav, started today at 2 p.m. Sorry, started yesterday at 2 p.m. This morning at yesterday at 10 a.m. and this morning at 6 a.m. In that case, it's 1 day. If it's continued further, it's more than 24 hours, so it's SP3. If it's started on the day of the survey, it is to be excluded. And this is a table I had helped in preparing for the global PPS. And once again, it provides a summary of what's what. And the key aspect is if the antibiotic prophylaxis was stopped more than 1 day before the survey, it's not to be included. And if it started today after 8 a.m., it's not included. And once again, this is something helpful that people carrying out the survey should be familiar with. When it comes to surgical prophylaxis, the WHO PPS also refers to the site. So, for example, if you're doing a surgical procedure related to the urinary tract, you're preventing urinary tract infection, so you have to add UTI. The unknown aspect should be avoided as much as possible because it will make you none the wiser. If you start inputting a lot of unknowns, you will finish quicker, but you can do pretty much nothing with your data. So once again, I reiterate, if it's not documented what kind of surgery it was, ask the team, and usually will come to a conclusion that it is one type of these procedures and this list. The actual diagnosis, when there's treatment, there's various, and here I only included the abbreviations, but there's definition of each one in detail in the protocol. For example, respiratory tract, there's bronchitis as opposed to pneumonia, there's cystic fibrosis, so there, with respect to urinary tract, there's cystitis as opposed to pyelonephritis, and pyelonephritis, some people refer to it as urosepsis, and obviously an upper urinary tract infection is more serious than a lower urinary tract infection. With respect to antibiotic treatment, there's another slightly different slight difference from the global PPS, where we have a start date for the treatment in the indication form and start date antibiotic for the antibiotic form. What is the difference here? So the start day of treatment refers to the first antibiotic used for the treatment of a current infection. Let's say 1 week ago, the patient was started on co-amoxiclav, but 2 days ago, the CNS report came in, or the patient was not improving, and the drug was changed to piptas and vancomycin, for example. In that case, the start day treatment would be 1 week ago when the co-amoxiclav was started. But start date antibiotic, the antibiotics that the patient is on at the moment, would be when these antibiotics were introduced. So 3 days ago, as I said in my example. Indication count. So the indications are listed as 1, 2, 3, 4. Usually you will not have more than 2, but you can list a number of indications. If the antibiotic cannot be linked to any indication, it should be kept empty, but usually, and you will find an indication. So this should be very rare. Once again, if you have unknowns, you cannot do much with your data except asking for better documentation. If there is more than one indication, and this question has arisen before, for example, amoxicillin used for both for urinary tract infections, cystitis, and pneumonia. Both 1 and 2 should be listed. Oops, sorry. So you put 1,2 and the dedicated space in the form. Another aspect is that in the global PPS, you don't look at the prescriber type, but here we do. And there are specialist physicians, GP. Now, GP does not necessarily mean general practitioner in the community. There are many medical officers who work in a hospital without an actual specialization or traineeship. So that's what's referred to here. Then there is other, because you can have non-clinical prescribers. So that's what other is referred to. Obviously, the unknown option is still there. Route of administration, I will not go into too much detail there. Missed doses, I will mention later, so I will not go into much detail. Guideline compliance, obviously, if you do not have any guidelines in your country, you don't try to say, okay, let me see if they're following any US-based guidelines. No, the guidelines have to be specific to your country, ideally to your institution. And treatment type, what the GPPS refers to as targeted here is referred to as directed, and empirical is the same. So directed is like targeted based on microbiology information. Empirical is based on the clinical diagnosis only. So going to the out of stock examples as well. So I have 4 aspects listed here, but I will go through the first 2, not to waste too much time on this. So if an antibiotic, A, amoxicillin, is unavailable for 3 days, it should be listed in the antibiotic out of stock list. However, if one particular product of amoxicillin is missing from day 1 to 5, but available on day 6, while another product of the same antibiotic is available in the different days, then if there's, so if product A and product X and product Z cover the total availability of a product, they should not be listed. But if there's a gap, and in this case there is a gap, then it should be listed. Missed doses. So as I was saying, in some countries, you can have issues with stock availability, issues with patient not being able to purchase the drug. So this is something that happens frequently, and the few actual trainings I had with hands-on experience there, I've seen it that patients buy a number of doses, miss some doses, and they restart when they get sufficient funds to continue buying the rest of the treatment. There could be other reasons, and they could be multiple reasons. For example, if the patients are buying the drug from the hospital pharmacy, it could be that for 1 dose they missed it because it was not available. Then the next batch was more expensive and the patient could not purchase. So it would be a multiple reason. So it was not taken for multiple reasons. And all these items I'm mentioning here, I'm just skimming through them. Much more detail is available on the actual protocol. And as I said, the purpose of this presentation is to give an overview, not the full detail of the actual protocol. So here, if we take the last case only, if patient A on day 2, the second and third tablet were not administered because antibiotic was not available, the number of doses missed would be 2, and the reason would be S, stock out issue. The other 2 examples are there so that you can look at them, but I don't need to go into the detail of giving 3 examples for each of these examples I'm mentioning here. The microbiology form is mandatory, but from what I've learned between 2018 and 2019, because last year, obviously, because of the pandemic, things went a bit down the drain. Many hospitals that participated from low and middle income countries, especially in this case, it was from sub-Saharan Africa. Very few hospitals have a fully functional microbiology lab. So they might have the lab, but they might not have the media. So very few C&S reports, for example, were available. Some percent pitfalls to look for. So with respect to data collection, it's important that the right details for the patient are entered, because if you need to go back and check data, you must be sure to be looking at the same patient files. Also, the investigators must be familiar with the files and diagnosis. As I said earlier, often the diagnosis is not just written as per our case definition or pneumonia. So as I said, if it's lower lobe consolidation from a chest X-ray, the auditor must be able to interpret that as a pneumonia. If nothing is written whatsoever, ask the ward staff. As I said, you shouldn't intervene, so you shouldn't say, I don't think this is the right drug, you should switch to that. No, but you can ask what the treatment intent is. With respect to data entry, once again, right details must be submitted, and the officer inputting the data, which might or might not be the same person who entered the data on the paper forms, must be able to read what you've written. So some people, pointing fingers at the undersigned, have very illegible handwriting. It's important that you try to write legibly to make the life of the person entering the data less difficult. If the person entering the data on the software is not sure what is written, it's important that they ask. And that's why you need to know who the auditor is. Obviously, if you input erroneous data, erroneous output will come out. So that's important across the board. This I've already mentioned. At hospital level, if you're participating as part of a country initiative, at hospital level, there is nothing which is optional. That's decided at the central level. Some aspects of the forms, I will not go into the detail about the forms, but at hospital level, the total hospital beds as opposed to the hospital acute beds is not always the same, because you can have day case beds which would not be included in the acute beds, but would be included in the total beds. Or you might have a long-term care ward. So those are not part of the acute beds. So these two are not the same. Also, hospital included patients and eligible patients. In large hospitals, according to the WHO methodology, you can sample patients, as well as in some countries there is either a consent form from the medical director or a consent form from consent request from the individual patient or carer. So the number of eligible patients and the number of included patients might vary even from that aspect. So an eligible patient might refuse to participate. So it's not a standard that each patient needs to endorse, but if at national level they decide that each patient needs to approve participation, then the number of eligible patients and the number of included patients will obviously be different. At ward level, the same, total patients and eligible patients might not be the same, as well as eligible patients and included patients for the same reasons I've described earlier. With respect to patient details, I know the slide on the left-hand side is not clear, but the aim is not to go into the actual forms, but the top part would be mandatory fields, the bottom part would be optional fields. And as I said, there's nothing optional at hospital level. With respect to age, there are 3 fields, number of days in neonates, number of months up to 2 years, number of years over 2 years. You only fill one form. So you don't say 3 years, 2 months, 5 days. If it's 3 years, it's 3 years. The months and the days are not important. If it's a neonate, 1 day as opposed to 27 days make a big difference. If it's a toddler, so from 1 month to 24 months to 23 months, you write the number of months. And this is explained in the protocol, as I said, but just some notes to keep in mind. Something I've seen is sometimes they fill the surgical prophylaxis duration without the indication being surgical prophylaxis. So it does not make sense. I reiterate, as much as possible, avoid the unknowns. And I've also seen auditors missing data or forgetting to input some of the data. It's important that you have complete data, otherwise it's virtually a waste of time if you have a lot of missing information. Some examples from experience. So these were 2 hospitals that participated in a pilot, and in the adult ICU, the eligible patients was listed as 3, and included patients was listed as 7. Obviously, these should have been the other way around. So that's important that the data is entered correctly. Here, once again, highlighting the issue with blanks and unknowns. Here we have 2 the same hospitals. The second hospital left a lot of blank data, which could be anything, and hospital 1 had a lot of unknowns. And with all those unknowns, it's a bit used as the data. Obviously, in the case of patients admitted to medical wards, this is about the type of surgery since admission. If the patient is not a surgical patient, the answer should be not applicable. So blank and unknown should not be listed, should not be marked in your data. This is another example. So surgical prophylaxis without a site, or completely undefined site with no systemic inflammation, and then listed as community-acquired pneumonia. I mean, these kind of data highlight issues with data collection and/or data entry. I mentioned this already. It's important that each auditor carries out a pilot phase so that they know what they are meant to collect. And an example would be that the same 10 patients are assessed by all auditors, and then compare the outcome and see if there's congruency or there's differences between the results. And obviously, if there's differences, the gold standard, the team leader should clarify what's meant to be collected. And in this way, carrying out a pilot phase, it will minimize the blanks, the wrong data being entered, and similar errors.
Peter, just to say, if we can go for another 5 minutes so we can take some questions as well. Thank you.
Get specialists on board. So if you're doing pediatrics, get a pediatrician on board. Use all sources of information like file, treatment chart, admission book, or whatever kind of information there is on the ward. Investigators must receive the protocol and the data collection forms well in advance so that they are familiar by the time. As I said, currently antiretrovirus, etc., are not collected, but it might be in the future. Last two slides. What's most important is good communication at national level. So the national team with the hospitals, and at hospital level, the hospital team with the wards. And now it's time for the Q&A. So I was not looking at the chat, so I'm not sure what the
No problem. I can, that's fine. Anna's also been answering some questions, which is really helpful. So if there are any questions that colleagues feel have not been answered, again, if you can recopy and post them, I'll ask them to Peter. So just one from Adita here. In case of standard fixed dose combinations like for tuberculosis, do we define every antimicrobial or just the FDC and the WHO ATC code?
At this point in time, anti-TB therapy is not included because there's a different network for tuberculosis surveillance within WHO. But in the future, it should be, it should be all items as listed in the WHO collaborating center. So if it's ethambutol, isoniazid, rifampicin, I don't know how they're listed.
So thank you, Peter. For the GPPS, where they do collect, they use the code. So for example, J04AM05 is rifampicin, pyrazinamide, and isoniazid. So Anna's answered that in the chat. There's a question I saw here about co-amoxiclav, 8-hourly, which was from pharmacist Laco, I think. In the UK, co-amoxiclav is 8-hourly for us. Is it 12-hourly in some countries?
In Malta, we have both options depending on the dosage. And I'm speaking about the oral. The IV is always, in Malta, is always 3 times daily. Obviously, I'm not speaking about renal insufficiency where you need to adjust dose. I'm speaking about the standard dose. So in Malta, the IV is always, the parenteral is always 3 times daily. With respect to the oral formulations, we have those that are 875 milligrams or more of amoxicillin can be used twice daily. For example, co-amoxiclav 875-125, often referred to as the 1 gram, that can be used either twice or 3 times daily. Now there are other formulations which are 1 gram of amoxicillin and 1 to 5 of clavulanic, which are only intended for twice daily use.
So I think the summary is it depends on your country and depends on what formulations you have available.
Yeah, and the ratio of amoxicillin to clavulanic.
Yeah, so it's about the
7:1, etc.
Yeah, thank you. In situations where most patients receive surgical prophylaxis during or immediately after surgery, how can this be recorded?
Actually, during, if it's a stat dose, it's a stat dose. Technically, it should be started before the first incision because clinically it's useless if it's administered after the incision. But that aside, if the procedure was carried out yesterday, if we're carrying out the survey today, if the procedure was carried out yesterday at noon, for example, and the drug was given any time between 10 a.m. and 10 p.m. yesterday, that's included. Now, if it's a stat dose, it's SP1. If it's 24 hours, it's SP2. If it's more than 24 hours, that is, it's intended to be continued today and possibly even tomorrow and thereafter, it's SP3. So it's more than 1 day. I don't know whether that answers the question.
Yeah, I think that should be fine. If it's not clear, please do feel free to add again into the question. So there's one here. What if the microbiological report has been telephonically communicated and the actual report will be sent in a day or 2? I'm assuming the question is, how do they record that?
Well, if it's been reported
If I could just ask you
verbally,
to speak up a little bit, sorry.
if it's being reported verbally, it should be somewhat documented in the minutes in the patient file. If there's no evidence whatsoever, I mean, but somebody tells you, listen, the microbiology lab called us and they told us there's E. coli susceptible to co-amoxiclav. Well, then ideally you should either log in into the laboratory information system if it's available and get the information from there, or jot down the information and fill in the information accordingly. If you do not have access to the actual CNS report, either verbally or soft or hard copy, then probably it would be best to eliminate, because it's just by hearsay. There's no evidence of the fact.
So, Peter, just to summarize, what you're saying is that if the person completing the form has the information directly from the lab verbally, they can record it down, or if within the notes, somebody has said the microbiological lab has called us and said X, Y, and Z, that's also recorded in the notes, so that's fine to also include. Is that right?
Yeah.
Okay, thank you very much. So there's a question about antimalarials and ART. Are they recorded in WHO PPS? I think this is a common question.
So, highly active antiretrovirals and...
Sorry, your voice is low again, Peter, sorry.
Highly active antiretrovirals, antimalarials, anti-TB, for the time being, it might be that in 2022 it will change, because the idea is to go to, like the CDC, a 5-yearly, every 5 years there will be the survey running in a country that has decided to participate. It might be that in the future, it is actually likely that in the future they'll start being recorded. But for the time being, it's not recorded. So ART is not recorded.
Yeah, so ART, antimalarials, oh no, is that anti-TB not recorded, antimalarials?
No, anti-TB, antimalarials, and highly active antiretrovirals are not recorded.
And not recorded in WHO PPS, but they are recorded in global PPS.
Yes.
Yeah. We'll go through this again, and when we go to the slides, it just talks about the summarizes the similarities and differences. We've got people saying thank you for wonderful sessions. So thank you again to Peter and to Anne for really great presentations. Really grateful for that.